Hello, everyone. My name is Ahmed. I'm a third-year pathology resident, and today I'm going to be talking about acute promyelocytic leukemia with PML RARA Fusion. This is an acute myeloid leukemia that is characterized by predominance of abnormal promyelocytes and the characteristic PML RARA fusion. This fusion results in a formation of a protein that would silence genes that are responsible for differentiation of myeloid cells, and as a result, you're going to see predominance of promyelocytes in these patients. This acute leukemia can be treated with ATRA and arsenic trioxide because these drugs would target the PML RARA protein. The arsenic trioxide would promote degradation of this protein, and ATRA, also known as all-trans retinoic acid, is going to bind to the RARA portion of this protein, resulting in a conformational change. And this conformational change is going to result in loss of function of this protein. And as a result, the promyelocytes are going to differentiate into more mature myeloid forms. Given patients, treatment is actually very important, and they have to be given this treatment as soon as possible because these patients can have disseminated intravascular coagulation because of disease-related thrombocytopenia as well as hyperfibrinolysis. And they can actually be cured with this treatment. This acute myeloid leukemia accounts for about 5 to 8% of all AML cases in younger patients, and most patients are between the ages of 20 to 59 years old. Clinically, I used to think that patients with acute myeloid leukemia, they need to have leukocytosis, but throughout my hematopathology rotations, I learned that actually patients with acute myeloid leukemia can present with leukopenia. And so is the case in acute promyelocytic leukemia, as about 2/3 of patients present with leukopenia. On the other hand, patients who present with leukocytosis or with a leukocyte count of more than 10,000 per microliter are categorized as high-risk patients. Morphologically, the bone marrow is usually hypercellular, but aspirate smears may be aparticulate in some of the cases. And the abnormal promyelocytes in acute promyelocytic leukemia are considered equivalent to blasts in terms of blast enumeration. There are two morphologic variants of acute promyelocytic leukemia. There is the hypergranular or classic variant, and then there is the microgranular or hypogranular variant. And these two morphologies may coexist in some cases. Now, let me show you a case of a patient with acute promyelocytic leukemia. So, this is the peripheral blood smear of a 67-year-old female who presented with fever, and then she was found to have leukopenia and blasts. As you can see here, looking at the red blood cells, for example, if we go here, there is a lot of white spaces between these red blood cells. So this patient is anemic. I don't see a lot of platelets. So this patient is thrombocytopenic as well. And I don't see a lot of white blood cells. So this patient is leukopenic. So we do have a patient with pancytopenia. Since the white cell count in this patient is less than 10,000 per microliter, this patient is not a high risk patient. Further stratification to low risk versus intermediate risk would depend on the platelet count. If the platelet count is less than 40,000, then this is an intermediate risk patient. And if the platelet count is more than 40,000, then this is a low risk patient. Our patient here has a platelet count of 55,000 and white cell count less than 10,000. So this is a low risk patient. And as you can see here, even from low power, we do see some abnormal cells like these two cells here. Now, let's go high power and look at these cells. Now let's go even more high power to look at these two cells. And what stands out for the morphology of these two cells is that they are bilobated. You can describe this one as kidney shaped, and they do have a lot of granules. Now I put some oil to help me visualize these cells on even higher magnification. And now you can see that we do have a lot of pink granules in the cytoplasm of these cells. They are intermediate to large in size. They have open chromatin, and we do see some prominent nucleoli like this one here, this one here, this one here, and this one here as well. So whenever you see this morphology of bilobed nuclei with a lot of granules, you should be highly suspicious for acute promyelocytic leukemia. Now let's go around and see if we do have more atypical cells. This one here, going on higher magnification. As you can see, this one is bilobed as well, but it doesn't have a lot of granules. Now, this one here is a truly bilobed nucleus. You can see that we have one lobe here, one lobe here as well, and we do have a lot of granules. So far, we're going around, we do see these cells. These are blasts. They have open chromatin. They have prominent nucleoli. They have a lot of granules. And this one here has big, chunky granules. So morphologically, I'm very concerned about acute promyelocytic leukemia. And whenever you're concerned about acute promyelocytic leukemia, you have to let the clinical team know as soon as possible because these patients can get disseminated intravascular coagulation that can cause death. Now, this is the peripheral blood smear for this patient. And now let's have a look at the bone marrow aspirate. Now I'm going around and I do see some cells here that have a lot of chunky granules, like these two cells here. And in this field, almost all of the cells that I see are blasts. This is a blast here. This is a blast. Or now looking at this, I do see some blasts. Like this one here is a blast with two prominent nucleoli. This one here is folded with a lot of granules. These two have more chunky granules and they do have prominent nucleoli. These two here are blasts. Some of these are atypical promyelocytes. So we do see a lot of atypical promyelocytes. We do see a lot of blasts going around. And here we do see more. And some of them are binucleated, some of them are kidney-shaped, and some of them are folded. And whenever you see this morphology, you also have to suspect myelomonocytic leukemia. However, as you can see here, we do see a lot of granules, so that should push you more towards acute promyelocytic leukemia. Now, here I'm looking at this bone marrow aspirate smear. This is a more cellular part of the smear. We do have some cellular parts here and there. Let's go high power on this one. And we do see a monotonous population of cells that have large nuclei, some prominent nucleoli, a lot of granules, and not a lot of cytoplasm. As you can see here, these are all monotonous atypical cells. And upon enumeration of 500 cells in this bone marrow aspirate, we counted 86% blasts. Now, for the same patient, we're going to look at the bone marrow core biopsy. Now I'm getting in focus. And as you can see here, the bone marrow is hypercellular. The cellularity of this bone marrow is over 80%. It's packed with cells. And now going on high power. I'm gonna need more oil to look at this on high power. So as you can see here, we do have sheets of cells with open chromatin, prominent nucleoli, and eosinophilic cytoplasm. And going on high power here, we can appreciate that some of these nuclei are bilobed, some of them are kidney shaped. So the bone marrow for this patient is packed with atypical cells. Now, as for the immunophenotypic findings for patients with acute promyelocytic leukemia, the atypical cells are characterized by high forward and side scatter because they are large and because they are very complex with all these granules. Characteristically, they are both CD34 negative and HLA-DR negative. CD117, CD13, and CD33 are positive, and CD64 is almost positive in all of the cases. CD56 is positive in about 10% of the cases, and these cases tend to be CD2 positive as well as CD34 positive. And CD2 and CD34 positivity is more frequently seen in the hypogranular variant of acute promyelocytic leukemia. Also, interestingly, CD2 positivity is associated with FLT3 ITD mutation in patients with acute promyelocytic leukemia. And these patients with FLT3 mutation, they tend to have a higher white cell count. And as we said earlier, higher white cell count is seen more in the microgranular variant of acute promyelocytic leukemia. And CD2 expression is interestingly found more frequently in the microgranular variant of acute promyelocytic leukemia. Now, let's look at the immunophenotypic features of this acute promyelocytic leukemia in this case. As you can see here, this is our dim CD45 population, but it's not actually dim. We do have higher forward scatter and higher side scatter. We don't have a lot of mature granulocytes. We don't have a lot of monocytes, and we do have, and most of the cells that we see in this flow cytometry is our atypical population. This population is CD34 negative. It's negative for CD2, CD3, CD5, and CD7, which are the T cell markers. This population is negative for CD10, CD19 is dim, CD20 is negative, and CD38 is dim. But these features don't actually help us to differentiate this leukemia from other types of leukemia, and they don't have any significance for treatment in this case. CD33 is bright, CD13 is positive, and CD117 is positive, and that's typical for cases of acute promyelocytic leukemia. HLA-DR is negative. So for this case, the morphology was suspicious for acute promyelocytic leukemia. CD34 is negative, and HLA-DR is negative as well. CD123 is positive, and CD123 in general is a marker that can be targeted in acute leukemia. So whenever we have an acute leukemia that is CD123 positive, we report that, and we report the percentage of cells that are positive for CD123. Now going here, this is the monocytic tube. Our atypical population or blast population is CD11b negative, 16 negative, 14 negative, and CD4 negative. CD64 is almost always positive in cases with acute promyelocytic leukemia. But as you can see here, CD14 is the most specific monocyte marker, and it's negative. And generally speaking, expression of monocytic markers is rare in acute promyelocytic leukemia. And here, lastly, as you can see, MPO is positive, and MPO is a myeloid lineage defining marker. TTT is negative. CD79A is negative as well. So the summary of this immunophenotype is that this patient had a CD34 HLA-DR negative population that had high forward scatter as well as high side scatter. CD64 was positive. CD2 and CD56 were negative in this case. As for the cytogenetic and molecular findings, PML RARA fusion is actually identified in about 90 to 95% of the cases. However, some of the cases have cryptic fusions that might not be detected by conventional cytogenetic techniques, and additional molecular methods would be helpful in these cases. Cytogenetic alterations are identified in about 40% of the cases. The two most common are deletion 7q and trisomy 8. As for somatic mutation, FLT3 mutation is the most common somatic mutation and is identified in about 40% of the cases. It's associated with CD2 expression, and it is seen more in patients with high white blood cell count. Interestingly, there's a variant, RARA translocation acute promyelocytic leukemia, in which fusion partners other than PML would fuse with the RARA. Of these, the two most important are ZB-TB16 and STAT5B, because these two are associated with poor response to ATRA and arsenic trioxide. To make a diagnosis of acute promyelocytic leukemia, the essential criteria to make a diagnosis is identification of a myeloid neoplasm with increased peripheral blood and or bone marrow atypical promyelocytes showing the characteristic abnormal hypergranular promyelocytes or the microgranular blasts. They don't have to be over 20%. If they're less than 20%, that's okay. You also need the PML RARA fusion in a patient with no history of exposure to cytotoxic therapy. A desirable criteria would be detection of translocation 15-17. As for the prognosis of these patients, risk stratification is based on white blood cell count and platelet count at initial diagnosis. A white cell count over 10,000 would place the patient at high risk category. If the patient has a white cell count less than 10,000, then the platelet count would be the next step to determine the group. If the platelet count is less than 40,000, that would place the patient in intermediate risk category group. If it's more than 40,000, then that would place the patient in a low risk group. And generally speaking, long-term cure rates for patients with acute promyelocytic leukemia exceed 90% for both low intermediate risk patients as well as high risk groups. That's the end of this video, and see you next time.